Pleased to be here. Thank you for the invitation. I will present our work based on OEF and another current study that is under review. So, as you know, in acute stroke, reperfusion therapies aim to salvage the ischemic penumbra. The ischemic penumbra has been defined using PET, which is the most accurate technique for mapping the ischemic penumbra. That was defined by a decreased CBF, a high OEF, and a preserved CMRO2. But as you know, we can't do PET imaging in acute stroke because of logistical constraints. So DWI has been used to estimate the ischemic core, but in practice, almost 1/3 of patients may experience some part of reversibility, like in this case. When you take a look at the literature, studies comparing PET and MR have shown inconsistencies in the assessment of the ischemic penumbra. In some diffusion lesions, they were high OEF, suggesting that that was a part of the ischemic penumbra. So, since that was feasible to estimate OEF using DSC, we aim to assess what was the fate of DWI lesions with IOEF after thrombectomy. So we used the hibiscus stroke cohort, which was a cohort enrolling patients who underwent admission MR, then thrombectomy, and then the follow-up MR at day 6 to assess the final lesion. We included patients who had successful thrombectomy, which was defined by a MTK score of more than 2B, and who has undergone a DSC perfusion and a day 6 follow-up MR. So for the analysis, we perform a vision analysis where OEF were considered increased compared to the contralateral side. Then we also perform a voxel to voxel analysis where we measured OEF values within recovered, which means that they were present at admission DWI and not present at T2 flare follow-up, versus non-recovered DWI lesions. So we included 134 patients with volume of diffusion was 15 milliliter, and we observed that almost 1/3 of these patients had an increased OEF within the DWI lesions. And all these patients had a decrease of the infarct lesion from admission to day 6 of -4 milliliter. Conversely, those without increased OEF, which were 2/3 of our population, have an increase in the final infarct core. So this is an example. As you can see, there is the diffusion lesion, and in the diffusion lesion, OEF is increased. So at the follow-up, we observed that there was a huge reversibility of the diffusion lesions. This case is the counter example, where you can see the diffusion lesion and the OEF is not increased, so suggesting that there is no penumbra inside the diffusion lesion. So in this case, the diffusion lesion remains stable. In subgroup analysis, we observed that the diffusion lesion recovery was more important when the admission lesion was larger and the quality of the recanalization was more important. It means that patients with TK3 recanalization experience a larger reversibility compared to those with MTK score of 2B. So at multivariable associated, we found that an increase of OEF within the diffusion lesion was associated with the regression of the lesion from admission to day 6. At the voxel level analysis, we found that almost all the diffusion lesion with increased OEF were recovered by day 6 after successful thrombectomy. So OEF mapping may predict the recovery of ischemic diffusion lesion. So why does it matter? Since thrombectomy is increasingly used in large core areas, we need for more precise assessment of the core lesion. So biomarkers like OEF, which may assess the viability of the diffusion lesion, may improve patient selection for reperfusion therapies, especially for those with large core. So the next question we asked was, what about within the perfusion-diffusion mismatch zone? Since, as you know, despite successful thrombectomy, most patients experience infarct growth. The mean infarct growth reported in the literature is almost 15 milliliter. So like you can see in this case, where the diffusion lesion is relatively small, the patient achieve very good reperfusion with the MTK score of 2C, but he experienced a very large infarct curve. So for this study, we wanted to see if the biomarker provided by CERCARE may contribute. So we use exactly the same patient, and now we focused for the method on the perfusion-diffusion mismatch zone. So we performed semi-automatic segmentation of the diffusion lesion of the perfusion-diffusion mismatch zone using commonly accepted method. We performed nonlinear registration of admission DWI and day 62 flare. And then we define infarcted mismatch voxels and variable mismatch voxel. Infarcted mismatch voxels mean that the lesion was not present at admission DWI, but found to be present at follow-up. And variable perfusion-diffusion mismatch voxel were neither present at admission on diffusion nor at day 62 flare. Then we processed the perfusion map with CERCARE, and we did a semi-quantification of CBF, CBV, CMRO2, and OEF. So, among the 134 patients included, we observed that more than 100 had infarcted perfusion-diffusion mismatch voxel, which were relatively small. As you can see, median volume was less than 2 milliliter. And all the patients had variable perfusion-diffusion mismatch voxel with a larger volume of 13 milliliter. We found that infarcted voxel had greater impairment in CBF, in CBV, and in CMRO2. We did not find significant differences in OEF. Then we performed ROC analysis with tenfold cross-validation, and we found that relative CMRO2 has the highest area under the curve, outperforming CBF, CBV, and OEF. With this threshold of CMRO2 less than 0.66, achieve the following diagnostic performance. Then we perform a subgroup analysis on patients achieving full reperfusion, which is defined by a TK score of 3. And we found exactly the same results, that relative CMRO2 at the highest area under the curve, and the same threshold. At multivariable analysis, voxels with the relative CMRO2 of less than 0.66 were more than 8 times likely to infarct despite successful thrombectomy. So as you can see here an example, the first example that I show you, you can see that CMRO2 is mainly collapsed within the final lesion. So as a reminder, CMRO2 reflects the absolute value of cerebral oxygen consumption. Early PET studies have consistently shown that tissue with a CMRO2 decrease of more than 40% will undergo infarction even after reperfusion. In an older study from the 90s, including similar patient that we did, acute stroke patient, the authors found that sub-region of the perfusion-diffusion mismatch zone with the CMRO2 of less than 0.62 progressed to infarction at day 3. So our findings imply that the collapse of CMRO2 may precede DWI lesions in some instances. So we have shown that OEF mapping predicted the viability of the diffusion lesions and that CMRO2 mapping may predict the viability of the perfusion-diffusion mismatch zone. So why OEF is not the best biomarker for the perfusion-diffusion mismatch zone, while this is CMRO2, when you take a look at stroke literature, you can find this article of Sobeski in Stroke, where they found exactly the same results that we did. They found that diffusion lesion included voxels with low and high OEF, suggesting that DWI has lower specificity for predicting irreversible infarction compared to CMRO2. They also found out OEF was highly variable within the perfusion-diffusion mismatch zone, and they explained it because the perfusion-diffusion mismatch zone include both the ischemic penumbra and the benign oligamia. So the limitations are, as you can see, that those biomarkers are not yet validated against PET, that infarcted perfusion-diffusion mismatch voxels were small compared to those who were viable, that we included hyperacute stroke population with very short time from symptoms inset. So as a perspective, as you know, recent clinical trials have demonstrated the safety and the benefits of thrombectomy in large acute stroke patients. And this finding had challenged the reliance of on current method to assess the ischemic penumbra. So maybe the next step will be to include metabolic assessment to refine our definition of the ischemic penumbra. Thank you.
Thank you so much for sharing these extremely exciting results. Are there questions from the audience? I had a thought, and that is like I said in the very beginning, that when we calculate OEF, that is actually a measure of whether the capillaries allow oxygen extraction, and then obviously blood flow is, you know, the extent to which there is a blood supply. So in my head, even though we don't measure absolute CMR2 in the penumbra, it makes perfect sense that if you have the two pieces of information, is the blood flow, A, and then you multiply that with the OEF, the extent to which tissue can, you know, it allows oxygen extraction, that then you get all the information. But it is so beautifully shown here. It is really, really nice. Questions? There's one there.
Thank you for a very interesting talk. I'm wondering, your top limitation there is that CMRO2 and OEF isn't validated from DSC MRI against PET. And since we want to measure it in in stroke in this case, do you think it ever could be validated? You know, in the stroke setting, you mentioned earlier that it's unfeasible, and if not, how would you do that?
Well, we in Lyon, in the hibiscus stroke study, there was a part of the funds that were used to do PET-MR on monkeys, acute stroke monkeys. So we had the acquisition of DSC and oxygen PET, and we're currently working on this to validate the technique against PET.
Those will be some very valuable data to have for direct comparisons, please.
I must say, I find your results absolutely fantastic. I think this could be a major step forward for us. Now, my question is more to Sirka than to you, to get the most reliable OEF and CMRO2 measurements. What would you think is the best database, DSC MRI or CT perfusion? Or doesn't it matter?
So you asked, could you say what the last bit, the kinds of information you would have, you asked about, you would have available?
So when I provide you with CT perfusion data or with DSC MRI data, what would you expect would result in the most accurate OEF and CMRO2 measurements?
So I'm not Circ here, but I think from my, is there a comment maybe from someone? There's someone waving. Okay, my immediate, if we're to say to which extent do we get quantitative tracer concentrations so that our deconvolution techniques, also those in the software here, are most accurate, then you would think that CT provides you with the most accurate quantitative data. So, and whereas with susceptibility weighted imaging, that's a complicated issue. I mean, we know that there's reasonably good correlation between concentration and R2 star for the general gradient echo sequence most people use, and then some of us use spin echo to have microvascular. But that's under a number of assumptions that linearity is there. So for quantification, CT would be my opinion. I see Kim and Mikkel are user reasonably in agreement.
We are nodding yes.
Okay, good.
Yeah, but of course there's also the perspective. You could say that CT is just more available, and for that better, you could say that the interest in CT is greater, right? Because it's available. No point in having a perfect technique for modality that's not used as much as CT. And I agree
My
with
lab,
you that
we use MRI because we can't afford the neat CT scanner you have.
and it gives the best results. What could be visual? I don't know.
Happy world. Other questions?
Hey, just a quick one. Did you notice any difference between the different vendors of the MRI scanner? Like the CT, there were different vendors, got a different protocol to obtain the perfusion data.
Did I notice differences?
Is it the same MRI scanner you use for all the trial data, or is it different MRI scanner as well?
No, do you mean, did I notice difference between the CT and MR?
No, two different vendors of the MR when you looked at the data.
We only have one manufacturer for all the MR, so I cannot answer to this question.
Other questions? Yes, there's one here in front.
Nice presentation. So you are comparing this very fancy perfusion in MRI where you only use that one threshold for the DWI. So do you think that's a fair comparison, or do you think that there may be also, if you use the different thresholds for DWI, that you could also find differences within the lesion in the DWI
Yes,
measurements or ADCs
there
values?
there is difference according to the DWI thresholds, but most of the we use the most commonly used threshold for DWI.
Do you think it's the true threshold?
Yeah, but I don't know if this whether this is true, but this is the one who is used and for stroke. But maybe it depends. I don't know.
One can always question one's biomarkers, I think was the take home from the last. That's a very good point. And other questions? Otherwise, I want to congratulate you and the lab in Lyon with these exciting results. That is really brilliant. Congratulations.
Thank you.
Thank you.